Okay, I'd like to welcome everybody to All Things Dentistry. Today we're going to try a demonstration that we hope will enlighten you on how to section teeth. I'm sure you've all seen pictures and movies of people sectioning teeth, and you've even looked over their shoulders, but it's always very difficult to see what's going on. So Dr. Mark here has really helped us out. He's mounted some teeth and blocks to try to simulate the mandible. These are, of course, mandibular teeth there. And kudos to him for his chemistry set. He's gone through 3 or 4 different formulations of wax, acrylic, and plaster, trying to simulate something that's something like the human jaw. So he's done a pretty good job. It's not perfect. The problem we have is the teeth are very dry. They're desiccated. Instead of splitting like a piece of oak, they're going to split like a piece of crystalline glass and shatter on us. But try to ignore that a little bit. For demonstration purposes, I don't know if you can see it. We have red line on the lingual aspect on it and a black line on the buccal aspect, so you can try to be orientated on it. And I'll try to treat it like it is a tooth in the mouth. I may suffer a little bit for demonstration purposes. It's kind of like my crown prep in my sophomore class. It was the best crown prep I ever did. It was on my typodont. Of course, you could unscrew it and look at it in your hands, and it's a little harder to do it in the real mouth, I understand. But we want to demonstrate how to section teeth. Let me just start off with a couple basic principles on sectioning teeth here. When you section teeth, the red outline, of course, is the groove, and you want to come down all the way to the bottom of the pulp chamber here. And also, if you notice, looking from the buccal aspect, it's kind of wedge shaped. And the reason that is, if you just have a simple a groove like this for demonstration purposes like that, even though it goes all the way in. And this is my demonstration elevator here, screwdriver. It's just for demonstration. Special forces, we call it field expedient, but we'll just call this a demonstration screwdriver. When it gets in there, you turn it. If it doesn't go in all the way, it's just going to bind right here, and all you're going to do is just break out a little chunk of enamel. So you want it to go all the way into the tooth. So make sure your cut is at least 3/4 of the way through the cut, so that your elevator will go all the way in before you start to twist it and apply pressure. The other thing is you want it to go all the way down to the bottom of the floor, or the pulp chamber. If it's just up here and you put pressure up here, again, all you're going to do is just chip out a little piece of the top enamel. You want the binding point on your sections to be right there at the floor of the pulp chamber and somewhere near the middle of the tooth, deeper down in there. So there's your binding point on your elevators. That's where you want the groove to go. Now, it's a little scary at first when you start sectioning teeth. You think you're going to go too far and stuff, so you want to be a little careful when you first start out. You may even use a periodontal probe when you start making your first incisions, just to give yourself a little more confidence that you're not going too far. So we're going to start off with some real cases here. We're going to start off first of all with a radiograph of our enlarged radiograph of our block sections here. And you see, this is a pretty typical one. It's slightly mesial angle, but it's also probably a Pell Gregory 2 or maybe a Pell Gregory 3 submerged below the gingival line. And this is the case that we have right here. And we have a little bit of a chamois cloth here to try to simulate the gingival tissue over the top of it. Now, a little lesson on anatomy here. When I start to make my flap incision, you want to remember the lingual nerve in about 5% of the cases goes immediately distal to the third molar. So in my mind, even though it's a fully submerged teeth, I try to outline about where I think the third molar would be, and it's about right in there. Now, 5% of the cases, the lingual nerve is going to come down with a buccal nerve, and then it's going to branch off, and it's going to be just immediately linked distal to the third molar. So if you come through there and make a big flap, and you come back just distally right up the ramus like that, you're going to cut through the lingual nerve. So when I make my flap, I like to kind of aim for the center of where I think that third molar is, right about there. And I start on the lingual distal surface of the second molar, I come out there, and I come out buccally. Now if it's really, then you can come around with a buccal flap over here, and if it's really deep like a Pell Gregory 3, I'll make a vertical releasing incision up here. I like these better than an envelope flap, because when you do an envelope flap, you may compromise the periodontium on the first and molar and second bicuspid, but by just doing a releasing incision like this, which I do at a bevel, you minimize the amount of exposed tissue there. So we're going to try this with Bard Parker 15. So again, keep in mind your anatomy. This little red circle here, that's the lingual nerve coming there. You want to stay away from that. Start at the distal lingual surface. We'll see how this cuts through here. Not too bad, actually. and you do a releasing incision. And when I do that releasing incision, see my scalpel is going to be beveled about 45-degree angle distal. And why do I do that? Well, when you're trying to join these two surfaces, instead of trying to join a butt surface, you got two beveled surfaces. They can slide together and you get better approximation and less chance you're going to have an open tissue, open exposed bone there. And I just go around and do my peripheral incision around there. Now, as you notice, part of the third molar may be contained under this flap there. That's not a big problem. It may prevent it from being extracted. You can just simply elevate that. Make sure you get under the periosteum, because the lingual nerve's under there. It's not in the bone. It's in the soft tissue. So you get completely under the periosteum and gently reflect that. You can move that flap and the lingual nerve in total without any damage there. Let's see there. Oh, voila, tooth. And see, there's where we see the third molar, and it goes right about through the center of the crown. Again, when it comes to delivery time, you can just get your periosteal elevator and gently, don't stretch it, because you can stretch the lingual nerve there. Just work the little elevator down there, and see you have a fully exposed crown there. I need a little more releasing on this distal extension here. Kudos to Dr. Mark for his efforts here. This is about as realistic as you can get. Okay, now on this tooth, what I'll probably try to do here is it probably won't just pop straight out, as you can see here. I'll try to section it. Now, if it comes just straight down through the buccal groove, you'll probably cut off the root here. So I usually start about halfway up this incisal incline and come back at about a 15-degree angle and go down in about here. And then my bind point will be right about in there. And again, it's a groove in there. As you'll notice, you can kind of see that there's usually about a 15-degree angle between the root and the crown there. So if it comes straight down the crown, normally you're going to cut off the anterior root. Not always, every tooth's an individual, but the odds are that's what you're going to do. So we're going to start, and we're going to do a little prep around the outside of the tooth there, a little relief on the buccal side, a little bit on the distal side. See what I can get exposed, and we'll go down and try to section that thing accordingly. So we'll see how this goes here. Where's my periosteal elevator here? Let's see here. There we go. I need a little bit of canned. A little hard to see with all this stuff. There's going to be a little powder here. There we go. That's our gasified saline there. Yeah, again, I'm just using the, I don't know if you worked in wood shops, but when you have a table saw, you have a little guide line there called the fence, and it keeps the wood in line so you make the right distance away from the cut. So I kind of think of the side of the crown as like a fence. Keep it close to the crown. Basically, you're doing like almost like a crown prep on the tooth there as you go down into the periodontal ligament and a little bit of alveolar bone there. Now, one point you do want to save right here, you want to be real careful and judicious about not taking off too much bone around the distal of this second molar there, because if you have bone there, it'll eventually grow across here, but if you go down vertically and remove some of that bone on the second molar, it may not grow up vertically again. May have a periodontal problem. So just try to stay away from that distal corner of the second molar. And again, I'm just using, just gently following the crown. And with the electric hand pieces, they're really nice because you get feedback for it. We used to have the big hall drills, which was a pneumatic air-driven nitrogen gas thing, and it would cut through stainless steel and you wouldn't feel a thing. So these electric hand pieces are really nice, not just because they cut well, because you get a lot of good feedback on it. Sorry for the pause. Now, I don't know if you can see that a little better there. Let's get a little closer to the camera, but I've got a pretty good buccal groove here and a little bit of a distal groove because the tooth is going to go slightly distal as you elevate it in there. And I can almost feel sometimes I'll use this, what I call a 15 scaler as my sixth finger. You can't always see stuff, but you can kind of feel down there, and you can almost feel the furca down in there. So I do that a lot of times, and it gives me a landmark if I can at least feel it. Okay, now we're going to try to do that cut down to about the floor of the pulp chamber. One nice thing about working on these block teeth, you never have to worry about anesthesia. I'm using a little bit larger burr than normally to prevent from jamming up, since I have to say that normally I use a 702, this is a 703, but for demonstration purposes it cuts a little faster and doesn't jam up with all the plaster and stuff, since I don't have a saline wrench here. 703s are good for sectioning teeth, but they really take off a little too much bone when you're removing bone and going around the periodontal ligaments. So, in an ideal practice, you'd have a 701 or 702 for doing your alveolar bone preparation, and a second-hand piece or 703 to rapidly section through teeth. Okay, that's actually a little more preparation than I normally do on a live tooth because number one, these are brittle teeth. I know it's going to shatter, so I'm going to try to minimize the shattering, and also for demonstration purposes, but you get the basic idea. You get a cut here, and I don't know if you can see that, but it's a little wider wedge shape on the buccal than it is on the lingual there.
Right in the center, there you go.
Right in there, okay. And again, it goes down deep to about the floor of the pulp chamber, so we're going to give it a try here. With our, I like the Cogswell A. It seems to be the best one for doing this sectioning stuff, and we'll see here. Okay, we got some separation there. I'm not sure if it's the crown or just the old tooth and root. And I use this little Woodson a lot of times, almost like a peritome, kind of feel around the periodontal membrane here. And then you can use whatever elevator you like to get a good grip on there. Sometimes I like that with number 9 molt because it's got a little hook and curves in there real nicely. And again, see that little flap on there will come right off. Okay, we got to stop and put some cotton gauze down the patient's throat so he doesn't aspirate it, okay? That seems like as real as possible. Okay, there's our distal root right there. I don't know if you can see that. And again, I like to use this little Woodson. It's a nice, it's almost like a peritome feeling. Well, we got the whole crown and everything off there. Let's see there. I think I cut the crown off. Let's see what we got there. Yeah, we got a little bit of the teeth down there. Let's see. I think we got that a lot. One piece, didn't we? Yeah. Okay. Where's my... Actually, the two roots came out together, which happens sometimes. Yeah, they're a little closer than they looked on the radiograph. So I got both the roots out there. Inspect those, make sure they're all there. Okay, it didn't go exactly as planned, but that's all right. We recovered pretty well there. Again, the distal part's going to come out before the mesial part, as you can see from the radiograph there. That mesial part stuck and it's not going to come out. So basically, we took out this distal. Actually, I did a section right through there, a little bit off there. Took that whole thing off, and this part came out.
That's real life.
Well, that happens all the time. About 3/4 of them come out the way I planned, about 1/4 don't. But the thing is, it's completely out in one piece there. And I think there's some good teaching points there. So, again, watch out for that lingual nerve when you make the incision. Try to estimate where the central fossa is for the third molar and make it through there, releasing incision here. You got a nice wide flap here. It's wide at the base, so you got good circulation here. This is a bevel cut up here, so when you suture it, it's easy to suture. And you can reflect that distal part of that flap if you need to get access to deliver the tooth there. Okay, well, we got it out, not exactly as planned, but that's you're going to find out in private practice. It doesn't always come out exactly as planned, but you get the basic teaching points there, I hope. Okay.